Dr. Sachin Rohilla, you're present. Please come forward. Ma'am, we'll next to you.
Good morning, everyone. I'm here to present vision loss in idiopathic intracranial hypertension, a rare case presentation. A 44-year-old obese male resident of Dehradun, Uttarakhand, present to the OPD with painless diminution of vision in right eye since 4 weeks. He also has history of pulsatile headache since 1 month, which was not relieving with medication, no history of long-term steroid use, and he has past history of tubercular pericardial effusion 1 year back and took anti-tubercular treatment for 6 months. General physical examination within normal limits and systemic examination within normal limits. Visual acuity in right eye is lowered down to finger counting at 1 meter and PR accurate, and in left eye 6/6 and PR accurate. Pupil reaction in normal in size, normal in reactive in both the eyes, and direct and indirect reflexes are present in both the eyes. IOP and rest of the ocular examination within normal limits in both the eyes. On fundus photography, red arrow showing blur, 360-degree blurring in the right eye, green arrow showing vessel obscuration, yellow arrow showing disc margin blurred, and yellow round disc states of grade 2 papilloedema. On OCT, we have red arrow showing subfoveal neurosensory detachment. Systemic examination. MRI brain is within normal limits. On consulting with neurophysician, lumbar puncture was done, showing opening pressure was 28 centimeter of water with normal CSF component. So diagnosed as idiopathic intracranial hypertension. We have final diagnosis is idiopathic intracranial hypertension with right eye subfoveal neurosensory detachment. We gave him treatment astazolamide 250 mg QID for 2 months, napafinec multivitamins, and on follow-up we give him same astazolamide 250 mg BD for 1 week, and we stopped. Then we have improvement in symptoms, that is finger counting 1 meter to 6/36, improvement in headache, and papilloedema also got resolved, shown in this picture. Treatment on 2 months treatment, papilloedema resolved, and both eye have disc pallor present. On follow-up OCT, RNFL thickness decreases, that is, a red arrow showing subfoveal neurosensory detachment got resolved. On discussion part, visual consequences of papilloedema usually are limited to visual field defect and enlargement of blind spot. Macular abnormality such as intraretinal macular edema and hemorrhage occasionally causes visual acuity loss in papilloedema. Cases of subretinal macular edema in papilloedema are not well documented in medical literature. Hence, we reporting a case of 44-year-old obese male with anti-tubercular treatment for tubercular pericardial effusion since 3 months, now presented with complaint of headache since 1 month, with sudden painless diminution of vision in right eye since 1 week. So, ophthalmologists need to differentiate between visual loss secondary to optic neuropathy from vision loss due to macular abnormality, and study by GL-Best concluded that 1 to 2% of IH cases also have present with blindness in a given year. I am emphasizing on the part that all patients with IH need to kept under long-term follow-up with regular monitoring of visual functions. So here are some references. That's all. Thank you.
Thank you for your presentation. I wanted to know, was there any role of steroids in your case, and do you recommend your take-home message to do MRI in all such patients in the first sitting, and a lumbar puncture, as you said?
On lumbar puncture, if we have...
do you refer all these patients for an MRI and an LP?
All these, no. But maybe in some cases.
Cases with papilledema is what I'm asking you.
Yes, ma'am.
All patients undergo MRI? When you see clinically cases with papilledema, how do you manage them?
In papilledema, we first go for fundus photography. We see there is a papilledema is present. Then we go for treatment like first treatment like acetazolamide to resolve that edema, and we also looking for sign and symptoms of papilloedema, like for to rule out like optic nerve lesion, like we go for visual function test, visual field, and then pupillary reaction, and then many other things like color vision.
Sir, I would like to ask you this question, whether IV methylprednisolone would have helped in this case, because I had
That's
a
what I
similar
was trying to
case.
ask. That
Yeah, can.
role of steroids is also.
Ma'am, can I just, so wonderful case. I just, as ma'am was saying, I believe any disc edema, this kind of a case, one would definitely go for a neuroimaging over there. And I just wanted to ask, how are the pupil reactions? I mean, I think I might have missed the point there.
In this case,
Was there a-
no,
was
pupil
there an
reaction are
RAPD?
normal in this case.
Pupil reactions.
Normal in the case.
Any history of any drug intake?
Yes, ma'am. Anti-tubercular treatment, ma'am, for pericardial effusion, ma'am.
Okay.
So you said that there is a rare, this is a rare entity. So why do you think it is rare? In
Because
what way?
in IIH case we don't have patient have blindness, but in this case we have patient present with finger
What-
counting at the 1 meter.
What
at-
was the cause of blindness in your case? What do you think?
If disc edema is present, then there may be blindness due to presence of a tissue like known as intermediate tissue of Kuhn, present between optic nerve and retina, like a cushion. If that disc got disturbed, then we have patient macular edema like finding, and then patient may present with
I don't
optic.
think that macular edema really corroborates